And it is AskMed time again. Hello, everybody, and welcome to AskMed. Coming back to you on YouTube live. I'm Roop Sasi. I'm one of the assistant medical directors here at CPR. This is our periodic question and answer period where we take questions that have been asked to us from the paramedics in our catchment area and try to come up with answers that work. And I generally host, but of course, I'm never answering these questions alone. We've got our typical cast of characters here. We have Dr. Paul Miller, who's our regional medical director, myself, and Ian Buchanan and Maggie Vincent are assistant medical directors. And joining us for this one is Vanessa Copprich, who is one of our Hamilton medics and an instructor here at CPR. Hello, everybody.
Hey, repeat.
There we go. I always worry when we do the intro and everybody's politely quiet because I suddenly think we've got an audio problem, but clearly we don't at this point. How is everybody today?
Doing great. Thanks for having me.
I'm glad you were able to come aboard. Why don't we dive into some of the questions here and see what kind of conversation we could spark. Let me just make a couple of quick changes here and switch over here. Whoops, not that one, this one. The first question we have here is actually the first two are with regards to cardiac arrest. And the first one is, we have a cardiac arrest patient who appeared to meet TOR criteria after a prolonged resuscitation with no ROSC and no shocks delivered, but the monitor still showed PEA. We received the order for a TOR, but what is the difference between terminating resuscitation and pronouncement? Paul, we thought, yeah, I was hoping you'd put your hand up there because we've had this discussion a few times, haven't we?
We have, Rupi. I have just one quick question before I answer. I'm noticing that there's a mute icon on the central screen. Does that matter?
Nope. Nope. I can still hear you fine.
All right. Then, so here's where this case comes from, is that we've had at least one or two cases where paramedics have called for TOR, they've been granted TOR, but a patient remains in a PEA rhythm. And so at what point do we then determine that the PEA rhythm is either too fast or too organized to actually pronounce a patient dead? And it really highlights, I think, several important linguistic, but also legal definitions about the pronouncing of death, the certification of death, and what we in pre-hospital care in Ontario anyway refer to as termination of resuscitation. And these are three things that are not the same. So in fact, you can terminate resuscitation on a patient who you would not pronounce dead generally yet, because the termination of resuscitation decision is about things like DNR, futility, outcome to the treatments that have provided so far. And those things may or may not be the same time or occur at the same time as a patient is actually deceased, is actually dead. And so if we think about a really extreme example, you may have a patient with a pulse. You may have a patient who's breathing, but who you are bagging for, or you are doing advanced life support measures on, and then you are presented with a DNR. Where you make the decision to stop doing that advanced resuscitative type intervention, but the patient is...
Oh boy. I think we just lost Paul. That was going so well too, but he's on a mobile phone in his car. We'll see whether he has the opportunity to come back up here. Oh, wait a minute. I think he's coming back. Yes, in case you're wondering, this is in fact live television or live streaming. No, he tried to pop in and then he vanished again. Can we hear audio from him maybe? No. All right. Well, I think where I often go with this distinction is what he was saying about the linguistic issues between TOR, pronouncement, and certification of death. So for that, the TOR and the pronouncement are two different things. The TOR is that decision to stop a procedure, the procedure by which you're doing the resuscitation. And that's the order you're going to get from a base hospital physician that says, you know what, I think this resuscitation is futile, we should stop. That is separate from the pronouncement of death, which is actually a clinical determination that life has ceased. So we're talking about an absence of pulse, absence of respiration. There's no signs of perfusion, no clinical evidence of ROSC, no trajectory that says that the patient is going to survive in any way. And those can be, again, they can be separate. That's why you will often see on ACRs, there's a spot for a TOR and spot for the actual pronouncement. Oftentimes these happen at the same time because the TOR decision is stop resuscitating the patient, they are dead. And in some cases, like the PEA that is lingering or the agonal pulse that goes on for a little while, sometimes you do have to observe with the monitor after the TOR and ensure that the activity that you're seeing remains non-perfusing or that you've actually managed to trend to asystole. And Paul's not back yet. Does that fit with everyone else's kind of understanding of things? You want to chirp in a little bit there, please?
Yeah, and Rupi, I like what you said there just in your last sentence was about a non-perfusing rhythm. And so, that electrical activity that's captured on the monitor, part of the decision when you're making the termination decision is that whatever electrical activity is not compatible, that electrical activity is not compatible with life. There's not enough forward flow from the myocardium to support a blood pressure. And so that's why you're seeing electrical activity on the monitor, but still no pulse, no evidence of distal circulation, and why some time, as you said, is required between termination, resuscitation, and then pronouncement, because you're waiting for that non-perfusing rhythm and all of that electrical activity to sort of wind down as the patient becomes sort of more metabolically unwell without ongoing efforts.
Well, I was just about to say, I know that I've heard many times from paramedics saying, well, I can't get a TOR, they're still in PEA. And I think there's just so much more information to collect around that PEA before you can determine whether or not a termination is appropriate or not. And I think in many cases, while a PEA is still on the monitor, a termination resuscitation is appropriate. In some cases, it may be inappropriate to continue resuscitation. And so that's just one piece of the puzzle that you see that you need to put together for the base hospital physician when you call to ask for a termination of resuscitation.
Turn my audio back on there. Tech issues. I think the key there is that pronouncement doesn't necessarily mean asystole. And I think there's the difference between that sort of electrical determination of futility and the actual situation that the patient is in. And it's important to distinguish between the two. Maggie, do you have any thoughts?
Yeah, I was just to add on to that. Paramedics may also hear when they call for a TOR. And it's one of these cases where the patient is in PEA. They may have some discussion with the BHP. They may give the BHP, ask them to monitor non-permanent and monitor the patient's breathing and for any signs of life for a little bit longer to confirm before they actually are giving that pronouncement. I hope you caught that. I was getting a bit of feedback on my end.
Sorry, there was a little bit of audio distortion there. Could you want to give that one more try?
Yeah. So just to say that, also just for awareness, when paramedics are patching into OMC and they talk to the base hospital physician, if it is one of these cases where the patient is in PEA and they're given a TOR from the BHP, which, as Vanessa said, can be completely appropriate, even though there is still a PEA and there is some of that electrical activity going on. They're not to be surprised if the base hospital physician asks the paramedics just to keep the leads on for another minute or two and monitor the patient's breathing before they're actually saying, okay, time of death is this time, which would be the pronouncement time, which is a clear distinction between TOR and pronouncement. We've had some recent discussion about that at the OMC table, which is where the base hospital physicians meet regularly. And that was our kind of agreed path going forward. So just to make people aware that they may be having that discussion as well.
And I think that it's a bit of a holdover from more informal language where paramedics will call me as a BHP and they'll say, I'm calling for a pronouncement. And I feel this incredible need to correct them. Maybe I'm being pedantic, but it is important that, in fact, I'm not doing a clinical determination of the patient's death over the phone. That's just not something that I can do. But I can give you an order to cease your resuscitative efforts. And that's what's going on there. It's an important distinction to make. We had Paul for a split second and then he left. Oh, I feel for him. Next question is cardiac arrest question. Actually, I might, this would be a good one for Vanessa to chime in on. The question is, in a cardiac arrest where you have PCP and ACP crew, so you've got mixed PCP and ACP, and both are in attendance, can a PCP push epi under the ACP partner supervision? If not, what else could a PCP focus on in order to optimize a well-run resuscitation? I think the first question is the one that's easy to answer procedurally, and that's no. A PCP should not be administering ACP level medications at all, even if their PCP, or sorry, their ACP partner is standing right there. It's the ACP that has the knowledge, the certification, and has demonstrated the skills and judgment to do that. They understand the ramifications of giving it, not giving it, and so on. And so they're the ones to whom that task is delegated by the base hospital authority, not the PCP. That said, I think that you need to remember that drugs are not the fundamentals that make a difference in resuscitation. And there are a lot of things that a PCP does in a resuscitation that really, really makes a difference in the end. Vanessa?
Yeah, absolutely. I can think of so many things that our primary care paramedic partners can be doing and doing really, really well in order to help a good resuscitation move forward. And one of that being organizing CPR, excellent CPR. I don't think I can recall an arrest that I've run ever where I haven't had to, or I haven't thought it necessary to correct someone's CPR technique or speed or depth or rate. Also checking on airway, checking on the end-tidal CO2. And the primary care paramedics are experts at that. So let's focus on what you're experts at. You're experts at airway. Please be on the airway, monitoring the end-tidal CO2, monitoring the compliance. That's what you're trained to do. Also monitoring CPR, which, as I said before, people get tired and they say they're not tired, but they're tired and the compressions change and you got the monitor in the back row growling, growling at you saying, press harder, press harder. But if you watch their compressions, what it wants is recoil. What it wants is the person to come up off the chest more. And it happened again to me yesterday and I'll say, hey, can I just get you to come up off the chest a little bit more? They come up off the chest and it says, good compressions. And it's just like, and that's not something, like that's something that primary care paramedic can be expert at. Keep an eye on that CPR, keep an eye on that airway, watch the overall timing, keep an eye on everybody's sort of pace. They can also be collecting information if there's multiple PCPs on scene, collecting all the information in a way that's meaningful to the ACP for paperwork in a way that probably the firefighters or police can't do. So you have an excellent role to participate in an excellent cardiac arrest. The most important factors in a cardiac arrest we know are CPR and defibrillation, making sure those things go really, really well. Pad adhesion, placement, all these sorts of things, remembering a vector change at the correct time. Those are all cognitive offload for the ACP to put on the PCP, and that's where they become the experts really at the cardiac arrest.
Yeah, I like that a lot, Vanessa. From CPR's quality department, Carrie Schneider talked about her days on the road, and she made it her job in arrests to make the arrest environment as well organized, tidy, set up for the whole team as possible, really with that idea of optimizing the things that we know work for the patient. So similar vein, but she really sort of described making sure everything, the monitor was in the right place so that people could see, equipment was within, arm's reach, really, following along in detail with the resuscitation and providing, all of the support that she knew that she was an expert at in those moments.
That's actually a really great way to put it, I think, organizing everything in a comfortable way for everyone and taking on that role and can be dynamic throughout a call as well. certainly when you're managing family members and external things like the heat in the apartment or the bugs or the million other things that we are managing. The primary care paramedic partners can be grabbing blankets for us to kneel on, or opening the window, or those are really important. Okay, not as important as CPR and defibrillation. Those are role number one, and that's what you guys are experts at. But the PCP role in an arrest is massive, and pushing the epi, while might seem to relieve cognitive offload for a half a second, we need you on those other things. We need you on those other things to make this successful.
I'm a big fan of that phrase of cognitive offloading, especially in a situation like this. I know that from running codes and so on in the emergency department, if I am head down and doing a particular physician procedure, let's say I'm getting ready to intubate a patient or so on and so forth, I'm focused on that task and I completely lose track of what else is going on in the room at that point because I've got my blinders on. The same thing happens with pretty much any procedure, especially at the advanced care level, where if you have an ACP partner who's concentrating on making sure the correct drug is drawn up, you might not have the whole picture. Oftentimes, the important person in the resuscitation isn't the one who's doing the things. It's somebody who's standing at a distance from the patient and keeping track of the entire room, or in this case, the entire resuscitation when you're on scene. I see Maggie nodding along knowingly when I say that.
Yeah, I completely agree with what everybody said. And to build off what you were saying, Rupi, I agree. The person who is kind of standing back with a bit of a bird's eye view is often the most important person, and really that role cannot be underestimated. And that's an opportunity to, for that person to be the true leader of the resuscitation. And that's where I see PCPs can have a ton of value as well, by just kind of, summarizing what we've done so far, making sure that everything's running smoothly. What can I do to support my partner and the patient right now? Kind of running through that circle in your head as you're going, I think is extremely valuable, and we shouldn't underestimate it.
Yeah. Maggie, even outside of providing leadership in the room, so when I'm resuscitating with multiple other physicians, sometimes the task I'll assign myself is making phone calls and getting blankets and air traffic control of people in and out of the rooms, trying to make the resuscitation environment as sort of smooth as possible with somebody else who's running the show.
I think I'd like to add too, just having so many new paramedics into this profession in the last handful of years, feeling safe speaking up in an environment where there are veterans. That's on the veterans to make sure that the comments are received well and safely, and so that our newer paramedics or maybe our more shy paramedics can feel free to take on that leadership role bravely and do an excellent job for us, and probably remind us to do all kinds of things that we would have forgot to do.
I think that is an excellent note to end on for that question, and we'll move on very quickly to the next, looking at the time. The next one is with regards to permissive hypertension or hypotension, or the more modern, more correct term now, restricted volume resuscitation or hypotensive resuscitation. But you want to talk about being pedantic, there I go. The question is, there's a lot of education around the principle of permissive hypotension in the context of multi-system trauma, including a lot of discussion around using MAP, so your mean arterial pressure, rather than SBP or your systolic blood pressure, as the ultimate guide for your fluid resuscitation. In a suspected bleeding trauma patient, should we be thinking about systolic pressure? Should we be thinking about MAP? Should we be thinking about signs of perfusion, or all of the above? There's a follow-up question, but I think I'm going to hold there and turn to the panel and say, MAP or systolic pressure? What do you think?
Maggie, you first.
Okay. Yeah, it's a good question, and I think if you look in the literature. In our discussions previously, I think Rupi made a good point, like in the sort of the OR ICU literature and the trauma literature, you'll often see MAP being used. But then you see SBP kind of being more used in the sort of pre-hospital literature and in the EMS kind of guidance. And at the end of the day, they're both numbers that can help guide what you're going to do. And I think maybe choosing one that you're more comfortable with and kind of sticking with that and using it in the context of the whole patient presentation is helpful, rather than kind of flipping back and forth between the two, if that makes sense. Because at the end of the day, it is a number, and you need to kind of put it into the context of what else is going on. What other clues to perfusion do you have? Is the patient mentating? What's their heart rate? What's the clinical picture? And how are you going to treat? I don't think that I have good evidence or reason to say that you should use, one number over the other necessarily. I probably use MAP a little bit more often in my own practice, but I just feel a little bit more comfortable with it. But I think using SPP to guide it, as long as you're taking that kind of bird's eye view, like I was saying, kind of into account, I think is totally appropriate. I don't know what others think about that.
I think. Sorry, go ahead, Ian.
I think that there can also be a bit of a tendency to hover over the monitor, chasing blood pressure after blood pressure, when really you've only made, let's say one intervention, one fluid bolus. Some of it is about keeping an eye on the trends and asking yourself what's significant. If the SPP is bouncing around a little bit because it's, a dynamic patient presentation, but the MAP is staying the same, it's worthwhile sort of noting that probably overall the patient's hemodynamics are unchanged. And so, just, allowing yourself to take in the sort of bigger picture in terms of how you think the patient is doing, I think is one piece of advice I'd give as well. Rupi, go ahead. Sorry.
No, that's quite all right. You kind of hit the highlights of what I wanted to go with. When I looked at trying to answer this question myself, I did go down that rabbit hole that Maggie talked about, where a lot of the pre-hospital and ER literature tended to lean towards the systolic pressure because it's fast, it's convenient, it's familiar, it's something that we're used to seeing. MAP tended to be more OR and ICU because oftentimes these patients are in more controlled, more monitored environment where they're receiving blood products and anesthesia, continuous monitoring, and vasopressors. The vasopressors are usually titrated to MAP. So that's the number that they're familiar with. It's not the number, it's what the numbers are trying to tell you that's more important. You don't want to replace one magic number with another or try to work it through that way. You want to look at the patient and realize that what you're trying to do is you're trying to under-resuscitate enough that you're not going to cause problems with hemorrhage. So you're trying to maintain enough perfusion for transport while avoiding the harms of over-resuscitation, like worsening hemorrhage, disrupting early clot with excessive blood pressure, diluting clotting factors with tons of crystalloid. But what you're not doing is ignoring a shock state. If the patient's in shock, if they're malperfusing, you got to give fluid. I really don't care what the number is. The example I dredged up, and it's a bit academic, but hopefully I can do this without having slides. There were two patients in the example, and there's one who they both have the same systolic pressure. So if you have one patient that has a BP of 90/70 and another patient that has a BP of 90/40, they both have the systolic pressure, but the MAP is very different. The first patient has a MAP of 77, the second one has a MAP of 57. So they're not the same. The MAP of 77 seems to be in much better shape, even though the systolic pressure is the same. That said, that patient with a blood pressure of 90/70 has this really, really tiny pulse pressure. And that could be a problem itself, whether it's vasoconstriction, low cardiac output, or compensated shock. So you really have to balance things out. And you lose a lot of that if you're just looking at the systolic pressure. And the flip side was also true. If you've got one patient with a BP of 90/60 and another one who's 120/45, they both have a MAP of 70. But clearly, one patient's hemodynamic status is doing a heck of a lot better than the other one. Having the same MAP doesn't necessarily mean the same volume status. So you really need to look at systolic pressure, MAP, that whole picture. What's the patient look like? Do they have signs of perfusion or malperfusion? What's their cardiac risk? What's the context? And honestly, how far away are you from a hospital is something that often has to come to mind as well. The concept of hypotensive resuscitation is fairly well entrenched now in the trauma literature. Vanessa, would you say that this is something that paramedics are doing universally, or is this something you find you still have to explain to people?
I think that people who have even heard of restrictive resuscitation have a really good idea of what they're doing. They understand MAP, they understand perfusion, they understand hemodynamic status, and all these things that are going on, and probably do a really good job of judicious use of fluid bolus in a trauma patient. And and for the people who are maybe a little less informed around this type of resuscitation in a bleeding patient, following our guidelines and directives are the baseline of what we do, and they're never going to steer you wrong. So following the directive around fluid bolus and hypotension, noting that hypotension technically is stated as less than 90 systolic, and it's going to guide you in the right direction one way or the other. So I think everybody's probably following the guideline, understanding what they know about the patient and whether your clinical knowledge is vast or smaller, following the directive, understanding hemodynamic stability, the trend of the patient, how things are going, all those sorts of things as a combination together, and understanding that unless the patient is in shock, judicious use of fluids may be something to consider. But again, we have our directive to follow, and that's why it's there.
And that's a good point. The directive does define hypotension by systolic pressure. So that's another reason why systolic pressure ends up kind of being your baseline for these discussions. The follow-up question was, if we choose to withhold fluids because we have a patient with a MAP above 65 and the perfusion seemed adequate, would that require a BHP patch? And I found that one unusual because you're basically calling a BHP for permission to not do something. It's a bit of it sounds a bit like a bit of CYA there. If you look at the directive and the way it's written, it says that for the hypotensive patient that's fluid depleted, consider a fluid bolus. And that word consider is doing a lot of heavy lifting there, because really that's putting that clinical judgment on the paramedic. Your clinical judgment would determine whether or not you give the fluid bolus. People are worried that, oh my goodness, if I give it, I'm doing the wrong thing, or if I don't give it, I do the wrong thing. You have those skills, you have that knowledge, you're able to make that decision. And honestly, if you find yourself in a sticky situation and you're not quite sure what to do, under those circumstances, absolutely call the base hospital physician. Will help you work your way through it. Sometimes even just talking to somebody else, whether it's a base hospital physician or one of your colleagues, helps you to organize your thought process, and you might come up with the answer even before they do.
Yeah, and your documentation skills are going to be the key here. You just tell the base hospital on your form what you're doing and why you're doing it, and if it makes sense and if it is reasonable, then it makes sense and it's reasonable.
In my show notes, I also have that little postscript. Don't forget that when you're doing hypotensive resuscitation in trauma patients, remember that it's not appropriate in patients who have to have their perfusion maintained because they have a traumatic brain injury or spinal cord injury. Keep that in mind. That's a postscript that's often forgotten. We got time for one more. We're coming up on the 4 o'clock hour now, and Paul is still a black screen. I really wish I could, on the fly, just kind of push that screen over a little bit and just, leave it from hanging there. But that's going to be something to work on. It's an analgesia question. The question asks that under the analgesia directive, we note that opioid analgesia and ketamine are available as options, but they're supposed to be given sequentially rather than co-administered. There are multiple studies that suggest the combination of opioids and ketamine can provide really good anesthesia in severe acute pain when they're given together, often reducing the need for repeat analgesic dosing. Can you explain the medical reasoning why the directive insists on sequential administration rather than concurrent administration? Everybody goes quiet when they wait for me to go on a pharmacology rant, but I try to rein myself in a little bit. You're right in that the two medications together work extremely well. That's partially because you're treating pain with two different mechanisms. Opioids act on the opioid mu receptor to try to take care of pain, the pain transmission, the way the patient actually perceives the pain, and so on. Whereas ketamine works on NMDA receptors, and that goes around issues of analgesia by modifying central sensitization to pain. That principle of wind-up pain gets around opioid tolerance in patients whose mu receptors might be a little bit messed around because of previous exposure to opioids, and so on. These two mechanisms have been shown that they work extremely well together. There is this is me nerding out. I pulled up the randomized control trial from 2012 that showed that IV morphine plus ketamine did in fact show superior analgesia to IV morphine alone. There's lots of information that shows these two medications do work well together. If you give the ketamine with an opioid, sometimes you can actually reduce the amount of opioid you have to give, and that reduces the side effects you would see from the opioid, like respiratory depression and hypotension and so on. So yeah, there's a lot of like pharmacological logic to why you might want to consider giving both medications at the same time. And Vanessa and I were talking a little bit before the show that it's easy for me to say that because I'm not the one who's actually pushing the drug in the back of the truck. And there are some practical considerations when you're treating a patient and you're the one administering the medications and making the decision about what medication to give.
Yeah, so I think every single, of course, patient that needs analgesia is going to be different and considered for different things for different reasons. But we don't work in an emergency room where we have a million tools at our disposal. We have what we have within hand's reach sometimes. And so in order to give, let's say, we're very used to giving opioids. We understand how to do that. We know what tool to have in the back of our muscle memory. But ketamine is a fairly new drug, and it does require reaching for a couple of extra tools that require consideration before we administer the ketamine. And also because we work in austere environments all the time, unsure, random things happen all the time. We need to be really careful with the drugs we give our patient and watch how they work. Let's try one drug. We have a moment to see how it works, and then we can add another agent for multimodal therapy if we need that. Just because we don't work in a really stable environment, we need to be a little bit extra careful. And we know that analgesia, while is an incredible piece of what we do, we can take the time to usually think about these drugs that we're giving, the timing that we're giving it, the way we're giving it. Is it appropriate to give fentanyl? I've heard that before. Fentanyl intranasally, and then consider ketamine if we don't have an IV. Well, then we have to start an IV, and then we need to draw it up in a 1 cc syringe, and then we need to put it in a mini bag. So all these things need to be taken into account, and it's just one of us doing it. So we want to make sure that our patient hasn't reacted adversely to the first drug we gave them while we're drawing up the second one.
Vanessa, the thought that comes to mind is the old adage from medical school that you can give it, easy to give it, but hard to take it back, or you can give it, but you can't take it back. So, I think in patients who are having, extreme pain, even after the first choice of first agent, dose of first agent. Again, like OMC is there to help you. If you feel like a patient is going to need something before the sort of routine dosing interval, that can be considered on a case-by-case basis as well. But by and large, picking an agent, running with it, and then seeing what your clinical response is the way to go for sure.
And then that's not to say you necessarily need to max out on one agent before switching to the other. I mean, I think the issue is more that you want to give the medication and give yourself time to assess the effect of the medication before you make the decision to give more. You don't want to get into the habit where you just want to slap them with absolutely everything at once and see what happens. You want to give the medication, give it time to reassess, determine whether you want to continue with the medication you just gave or whether multimodal analgesia is going to make a difference. And don't forget with analgesia that you've got other tools in your toolkit. Don't forget about the NSAIDs and don't forget about acetaminophen when you have the opportunity to do that. I see Maggie nodding if you wanted to jump in there.
Well, I really like your last point about don't forget about NSAIDs and acetaminophen because they do work and they're very nice to have going while you are considering some of your narcotics if needed as well. Obviously, there are some cases where you're kind of jumping to the narcotic for severe conditions where patients are in very, very acute pain. But don't forget about your basics as well.
Yeah, we just had a patient this morning who was having some severe abdominal pain. She was complaining of 9 out of 10 discomfort. And my partner chose to give her ibuprofen and acetaminophen. And surprise, surprise, by the time to the hospital, she was pain-free. It was like a miracle. So please don't take those drugs for granted. Give them, they work. That's why we give them.
Yeah, totally agree, Vanessa. We have some pretty good evidence, actually, in particular in acute back pain. And renal colic that anti-inflammatories on a pound for pound basis are essentially equal to intravenous morphine.
You want to make sure you pick the right agent, give it carefully, reassess the effects. I think that's what we're getting at here. Are there situations where you would pick ketamine over opioids or opioids over ketamine?
Yeah, I think you touched a little on it already. Patients who you're concerned maybe they have a very high opioid tolerance, or there's maybe some opioids already at play, and you think that that's not, you're going to have to give like many doses or very high doses of opioids, then ketamine can be a safer option. In your hemodynamically unstable patients too, where you're worried about potential hypotension from opioids, ketamine can be a really nice choice. Or where you're worried about respiratory status, ketamine is a little bit better on the respiratory depression than opioids are. So those are kind of my top three ones where I consider it.
I like a point that was made before the show when Vanessa and I were chatting, where we've all overheard some of our paramedic colleagues talking about wanting to give ketamine for difficult extractions or difficult extrications because you can dissociate the patient, and you want that little bit of that dissociative effect to help keep things nice and calm when you're moving a patient from A to B, especially if they have particularly painful injuries, trauma, broken limbs, that sort of thing. And there's a bit of a hazard in going that way, because the doses and the way that you're advised to give ketamine for analgesia, you should not be tripping into that dissociative range of the mechanism of action. We're supposed to be saying below that. And even if the dose is subdissociative, if you give it too fast, the concentration in the blood's going to spike enough and you're going to dissociate the patient. And even if you don't, you're going to be pushing further into that realm of dysphoric and adverse effects that the patient's not going to love. If you're going to give the ketamine for analgesia, don't think about the dissociative effect. Work on dealing with it as a pain control agent. Give it low and give it slow. I think that wraps up the questions at this point. We certainly did not get enough Miller in this broadcast, a certain lack of Paul Miller, but that's a nice segue to a couple of things I want to remind you of. On June 18th, CPR will be hosting their social CME, which we call Miller Time, with a social evening with Dr. Miller, where they'll be discussing cardiac arrest management primarily. And the paramedics in these situations are often the ones guiding the conversation. That's going to be held at Royal City Brewing and Beer Hall in Guelph. That information is on CPR's Facebook page if you want to take a look. As well, CPR's putting together a sim day where they're looking for paramedics who might be passionate about simulation. That's going to be held on June 30th in Cambridge, actually not too far away from where I live, so I may have to drop in and take a look at that. Thanks for bearing with me and with the blank screen in the corner. I think you guys all did an excellent job of getting through these questions and the answers, and I really enjoy the conversation with all of you. Thanks for coming.
Thanks for having me. Always a pleasure.
And somebody, but when I sign off, just could you text the regional medical director and make sure he's okay? Thank you. All right, I'm gonna sign off here. Thanks a lot for watching, and of course, if you've got questions and you want to submit them for AskMed, we're actually running a little bit short on questions this session, so please fire them off. Our web address or our email address is right there on the screen. It's askmed@cpr.ca, or you can get us direct messages through Facebook, Instagram, and so on and so forth. Thanks a lot for watching. We'll see you next time.